We'll get started. If anyone notices any audio issues or anything, just please let us know. We'll be watching the chat. Really excited to talk to you today. I'm Gretchen Roe. I'm here from Corewell Health, and we're going to be talking about the withdrawal from advanced respiratory support and the approach to symptom management, as well as interdisciplinary support. So with me, I have multiple members of our hospice team and interdisciplinary members within our hospital that support our patients during this very, sort of critical time in people's lives that we just want it to go just how they would want it to be. And it really requires a large interdisciplinary team for that. So that's why we have included all these experts on this lecture. So, and I'll introduce them before each of them speak. So I don't have any disclosures. So objectives for this time, we're going to talk about the preparation for withdrawal of respiratory support, as well as acute symptom management. We'll review the pharmacology of medications we commonly use, and support an evidence-based approach, and the evidence-based approach to as-needed PRN dosing, as well as infusion titrations. We'll talk about the respiratory distress observation score and the clinical application. And we'll talk about the involvement of the interdisciplinary team during the process of removal from advanced respiratory support. So I'll start with a case that we'll use during this lecture. So Cindy is a 42-year-old woman with stage 4 lung adenocarcinoma with respiratory failure. She has 2 children, ages 7 and 13. She'd previously discussed her wishes with her spouse and said if she was ever in a situation where she would never come off a ventilator, she would not want to continue with it and would want comfort care. So he shared this desire with the medical team, who then started planning for that transition to comfort care and withdrawal. Her parents and 2 siblings are having a very difficult time with this decision, as they've been praying for a miracle throughout this time. We have one one sibling who lives in California. The rest live locally and plan to be at bedside at the time of vent removal. So that's sort of a case that we'll get back to. But meanwhile, we'll start talking about medical management. So as part of this lecture, I want to talk about the journey to improving comfort care protocols over time. There's been a lot of changes and improvements in the last 8 years. I'm showing this article as this was very influential to me around 2018 when I was studying for my board exams and had really an aha moment of needing to change how we practice here at our institution. This article is published in 2017 from the University of Washington, where they worked on developing and implementing a comfort care order set that reflected pharmacological principles and expert recommendations. What they comment on is they noticed 3 main problems with their old process and order set, which was very familiar to how the struggles we were having as well. And those main points were that there was little guidance to clinicians and nurses for the management of pain and symptoms with opioids. Their older order sets allowed nurses to rapidly titrate infusions. And so let's say an 80-year-old could have a morphine infusion at 2 milligrams an hour in the morning, and by the afternoon be up to 10 milligrams an hour, because that was the primary way to improve symptoms, is keep going up on the infusion. There was also noticed that insufficient collaboration between the nurses and ordering providers. So the way they ended up, their process is a little bit different than how we may practice now, but just those key concepts were very influential in our program. I'm sure others around the country starting to relook at their protocols. So for our institution, we noticed before we made changes with there was titration of opiate infusions by the bedside nurse, and often in the comment section it said titrate to comfort, so pretty vague and not a lot of clear guidelines. And often that meant that opiate infusions were titrated every 60 minutes. The as-needed doses were often written as every 30 to 60 minutes for acute breakthrough symptoms. And this rapid titration of opioid infusions increased the risk of opioid toxicity and opioid-induced hyperalgesia. So over a period of a year, we made some very significant culture changes, which was hard, really hard. And we modified our order set to fit best practices, we ordered in that the infusions were at a constant rate, not titrated, and managed. They were adjusted by providers, physicians, and APPs. And the bolus dosing with every 10 to 15 minutes for acute breakthrough symptoms, so a lot more frequent. And then the opioid infusions were not titrated until they reached steady state, which is often 8 hours for most opioids. So the reason I share this history and where we are now is that I see all of you as fellows and our team members as leaders. Our teams and hospital systems are looking to us to guide them in the best practice for comfort care. So wherever you may go in your jobs for our fellows, I hope that you can look at the practices and look to see, are there any hints of the old practices that need to be adjusted, and then encourage your hospital systems to adopt these current best practices. So let's talk about the pharmacology of opioid infusions. Opioid infusions should be titrated only once steady state is reached. And given the half-life of opioids, it takes at least 8 hours for that opioid infusion to reach a steady state. So appropriate dosing and that titration of the as needed is that key factor in getting that more acute, urgent, like symptom relief while we wait for that infusion to reach steady state. So a key point is that the titration of our opioid infusions is similar in concept to how we titrate long-acting opioids. So for example, if we were going to start a patient on long-acting morphine, we calculate that dose. We figure out how much they're using of their short-acting, calculate then the most appropriate dose for that patient, and we may adjust that calculation to individualize it to what we think is best for them. So if we were to titrate, like for example, titrating the opioid infusion every 1 hour, which was the old practice, would be similar to increasing our long-acting morphine every 6 hours, which we wouldn't do. So this is why I'm a big fan of trying to find a calculated dose for these infusions. And I'll talk a little bit more on how you could consider doing that. This is a great review article published in August 2023 in the Journal of Pain and Symptom Management that talks through different practices for palliative extubation. They comment that despite the prevalence of palliative extubation and the impact on patients and families, there's very little literature to help guide us on the best practice. There's highly variable practices, even within one's own institution and between providers within a practice. There can be a fear of hastening death that can lead to undertreatment of symptoms, and there also could be overtreatment of symptoms. So this gives a little bit, at least some guidance to how people may be practicing and maybe some best practice options, but there's still, even within this article, a lot of variation. So my goal is to be able to summarize some of those key concepts, and I'll point out the things that I think are a must and very important and could be board worthy. And then there's also style. And that's okay, that there can be differences on how each of us approach this, but our general key concepts should all be the same. So some things that may not be exactly how I practice, but that are mentioned as options in this review article is for infusions to start the continuous infusion. If you're starting the infusion at 50% of the bolus dose, initial infusion rates can be based on response to bolus dose. That was sort of a more vague idea or recommendation. If patients receive 2 consecutive boluses within an hour, you can increase your infusion rate by 50 to 100%, depending on their level of comfort. So just some options there. This is a key concept, though. Steady state of the infusion will take 4 to 5 half-lives. That is standard and something we need to all keep in mind. So I think it's about 8 hours, and we use that just for all our opioids to keep it simple for our team. Bolus dosing. So bolus first approach, that is a key concept. If there was a board question, I would think they would say, use the bolus for immediate pain relief versus adjusting your infusion. That's sort of the next step. So bolus dosing, a lot of different approaches out there. Bolus dosing can be 1 to 2 times the hourly infusion. You'll see some institutions using half of the infusion rate. So wide variation there. It's probably somewhere in that ballpark. Administer a bolus dose prior to starting your infusion or titrating up, because you know that's going to take some time to have effect. So that's just that reminder that it's like a long-acting agent in that respect. And then this is the key concept. It's important to have our orders written with specific instructions. So our comfort care order set should have as much guidance and instructions built in as we can possibly do. And this should also guide providers on what symptoms we are addressing. Consider longer dosing intervals with those with end-stage liver disease. And then as far as assessment, there's really encouragement to apply the respiratory distress observation score, which is an objective measure for those who can't self-report their dyspnea. And we'll talk a lot about that. So I have this article reference here, and I recommend everyone taking a peek at it. Some other things they mention of midazolam, so our benzodiazepine. This is our benzodiazepine of choice for an infusion. And the reason why is because it has a faster onset than the razepam and also a shorter half-life. And whenever you're coming to an infusion, you really want what has the shortest half-life because you can more quickly get to that steady state and make adjustments. So that is why we always use midazolam infusions. There may be times when you don't need an infusion and the patient's a little bit more stable and doesn't need the back-to-back dosing that we could switch to a lorazepam. But when you're in that acute phase of coming off of any type of respiratory support, my recommendation would be midazolam. Propofol. Some patients are in the ICU. They're on propofol for sedation. What I feel is the best practice when possible is to add on midazolam infusion. And then once a patient's comfortable with that, try to wean off the propofol. I found that in 95% of cases, we don't really need that propofol because the midazolam has that sedative properties, amnestic, anxiolytic, does all those things, whereas propofol is only a sedative. So that's where I prefer the midazolam. There may be some situations you have patients with a lot of agitation that still requires some propofol, and I think that's okay to have some, and maybe at a lower dose. So it's not something that we absolutely have to get completely rid of. But I do find that midazolam usually is enough for most patients for the benzodiazepine portion. Steroids could be considered if a patient has a lot of allergic edema or high risk of post-extubation stridor. And a way to test to see if that's a risk is a cuff leak test, if you have the luxury of time, especially if you can plan a day ahead. So the respiratory therapist can do that test, and the amount of an air leak is inversely related to the degree of laryngeal obstruction. And in this review article, I have a table here of different protocols that could be used to give steroids. And a lot of these have about 24 hours worth of steroids prior to extubation. The literature does not support routine use of anticholinergics, Lasix, anticholinergics for secretions, Lasix for to prevent heart failure post-extubation, or methylprednisolone for stridor. So we don't routinely use those, but if the people at high risk, you can. I will say some people are still use scheduled Robenal, even though there's maybe not the best evidence for it. So that just may be different styles, which is fine. But just as far as the evidence, there's not great evidence for the anticholinergics. So let's show you an example of our order set in the under our opioids. We have morphine as one of the choices, and we have concentrated morphine, IV, PRN, and also infusion from the pump with PRN boluses. So the key things I wanted to point out is that we have listed here that we're showing what symptoms that we're treating. And we also have in a comment section that we will wait 8 hours for the infusion to reach steady state before we increase. So it's not a titratable, it's a continuous infusion. And for our boluses, I highly recommend having 2 options, a lower and a higher dose. That way your nursing team has some room to work with. We can go to the higher dose if that first dose isn't working. And there's specific instructions within here saying to maybe try the lower dose for a couple times and then go up to the lower dose first and go up to the higher dose if needed. And if that's not working, call. So we don't see with the specific order set, we don't see patients going for hours with uncontrolled pain. We're getting a phone call within an hour if things are not going well. And the other thing with comfort care order sets to think about, at least for our institution, is this is open to any provider. It's not just for our palliative or hospice team. So when we were creating this, we had to create it thinking anyone, people who don't have as much training in comfort care, we want to make sure that they have some guidance and also they're kind of safe, sort of a safe practice within that. So Power Hour, this is something that we ended up having a term for when we were going through that big culture change here at our institution, because it was really hard mindset for the nurses to say, well, I used to be able to just push that, continuous infusion button, and now I have to come in and get boluses every 10 minutes. I can't do that. I can't do that on the floor, maybe the ICU, but, I have 5 patients. So we really talked about, this is a really critical state for this patient, a time to always remember. This should have the same importance as someone who has chest pain, getting a chest pain protocol or code stroke. This is we need to pull in our resources and all hands on deck when someone's in a crisis or during that first hour coming off of BiPAP high flow event. So that Power Hour also is that time where we're dose finding. We're giving those PRN boluses of the opioid and benzodiazepine. And then we need to figure out, now what do we do after that? What do we do with the infusion? So we use that time to figure out how much it took to make sure the patient was comfortable, and then calculate our infusion rates if we're using infusions. Which is often the case for coming off of any kind of respiratory support, at least for the opioids. There are sometimes if someone's on low support of BiPAP or high flow that we will wait and see if we need benzodiazepine infusion, but pretty often like most cases, having an opioid infusion because it's just easier for our nurses to push a button and give a bolus and not drawing it up and wasting and all those things that can delay and take time. So in how we do this, again, I have not seen models of this in the literature of like how to calculate. I showed you what was out there, and there's not much guidance as far as how to calculate dose find an infusion rate. So this is what we have been doing for 6 years and found very, very good results from that. So we take the amount that a patient is used in the first hour of their opioid and divide it by 4. We divide it by 4 because it takes about 4, if you stack all those doses, that total amount could last up to 4 hours. And so that's what we have done, and we find it to be pretty effective. For a benzodiazepine, from the midazolam infusions, we take the total amount and we divide it by 2 because it's a shorter duration of action. The main medication for dyspnea and coming off of ventilatory support is the opioid. So that's the key thing. I know we typically give a bolus of both the benzo and the opioid before that first coming off, but those follow-up boluses should primarily be your opioid. So if the benzo is used just out of routine with every bolus, then that calculation gets too high. It's just more than the patient probably needs for an infusion. So just keep that in mind. But your primary agent is your opioid. So we'll have case examples of how to apply those calculations too. So the nurses, their main role is assessing those symptoms, using the PRN medications, and reaching out if the dose is not effective. Our providers really need to be available by phone, or sometimes we're in person during that critical first hour when there may need to be escalated dose adjustments. And then that hour, we call that hour after, where the patient is usually comfortable by that time with those good bolus dosing, and we can figure out what infusion rate will keep their symptoms very well controlled. And of course, our involvement of our interdisciplinary team members, which we'll hear more about. So our goal is that comfort care is delivered in a way that's effective, safe, timely, and aligned with patient and family goals. You may have a patient coming off BiPAP or high flow who wants to be more alert and interact with their family, and that does change how the medication dosing and what we do. Some other people might say, I want to be out. I don't want to remember this. So those are all important things to talk about as we make a plan. There's two main ways to come off of a ventilator. There's one called more immediate. Also, as in this review article, they talk about terminal extubation is another term used for that, where you give anticipatory good dosing of your opioid and benzodiazepine before coming off the vent. There's no weaning process. We just come off and then treat, again, symptoms after that. How that's sometimes tricky because you're trying to figure out what is that dose, because often they're not getting much of a dose before coming off a vent in the ICU. They've probably been withholding a lot of opioid boluses for sure. So a lot of how I pick that first dose is based on my experience, and every single case sort of adds up, and you know what worked, what didn't work, and that's really how I've come to figure out what that first dose should be. With a titrated or terminal weaning process, this is when a ventilator is titrated, but more in a rapid fashion within 30 minutes, with gradually decreasing the FiO2 gradually down to 21%, PEEP to 0, and a positive pressure to 5. So just gradually going down, giving boluses before each change, and rebolusing if needed, and even going back a step if needed on the vent settings. And the application of the respiratory distress observation scores encouraged, which we'll talk about next, during that process to really gauge if they need more bolusing or not. So this is really a spontaneous breathing trial to gauge the expected burden of symptoms after extubation. So I encourage you to try different methods and see, and the family may actually have a preference. Some of them like, I do not want to prolong this, let's get it done. And then you have people who, especially those who want to be more awake, and maybe that titrated approach is best, especially with high flow and BiPAP. I found that titrated approach really helpful. So what is this respiratory distress observation score? This is a score that was developed by Megan Campbell, who is a nurse scientist at Wayne State University. And so she developed this in 2008. And then a study of hers in 2010 further developed this reliability and validity of the revised RDOS score. There's 8 parameters, as you see here in the table: heart rate, respiratory rate, restlessness, paradoxical breathing pattern, accessory muscle use, grunting and expiration, nasal flaring, and look of fear. So those are all the things we assess. The score is between 0 and 2. And so for each one, so someone can have as little as a 0 or as high as 16 for severe distress. So some key points is that the RDOS score is the only known validated tool to objectively assess dyspnea in patients who can't self-report, has inter-rater liability. A score of greater than or equal to 3 signifies a need for palliation of respiratory distress. It's not validated in children, neonates, if the patient is quadriplegic, or if it's bulbar ALS. And patients' assessment during the withdrawal of mechanical ventilation or any type of respiratory support can be enhanced with the use of this tool. Our team actually has been applying this. I talk about it every year, and I'm like, we need to really implement it here. So our team has done a great job implementing this RDOS score. So they do it pre and post intervention, and also with daily GIP visits, and have it in a way we can document it in the EMR. This is helpful too, because you will come across times when bedside nursing teams wonder, why did you give that dose? Do they need it? And our practice can always be questioned. And so this is just one other way we can have a validated tool to objectively measure dyspnea. just for awareness too, these can be good board questions as assessment of pain, which can also be part of this process, is using the behavioral pain scale for intubated patients. The critical care observation tool is also an option for intubated or non-intubated patients. So go back to our case. Cindy, who has our lung adenocarcinoma, has her young children, and they're planning to come off the ventilator. We know just the importance of the whole team. Some are behind the scenes, like the pharmacist, the respiratory therapist is, part of this process, our providers, nurses. We have our chaplain, social work, and not every institution has all of the same resources. We're blessed to have music therapy, a child life specialist and team. So we want to share with you how our interdisciplinary team members approach this situation and with patients and families going through withdrawal of respiratory support. So I'm going to start having Carissa Scheidemann is one of our hospice nurses, and I'm going to have her share about the nursing role. Can you,
there we go. I think I'm on now. Hi, everyone. Just want to thank you for the opportunity to speak to, and as a nurse that has been here for both processes, for when we did the titration in the past, and now have moved to more of giving the bolus doses in the current protocol that we've been learning about today, this is much more effective. This is much more measured, much more and effective in getting those symptoms managed much more quickly and in a way that you can see before your eyes someone becoming comfortable and peaceful, and just much more comforting for families and also the staff beside this. I think it's been just a wonderful way that we can help our patients and families. So very effective. As the nurse, were they really there to give the medications for sure and make those plans with their attending team, who we work closely with to make sure, they've already had a relationship with this family. We're going to work closely with that attending team. The bedside nurse, of course, working as a team with them. We may do most of the dosing during that time, but we're going to work and communicate with that nurse, but preparing the room, getting a read on that room with the family. What are their goals? What have they experienced in the past? Prepping them for what they may see as their loved one goes through this, giving them those options to be in the room, to not be in the room, to prepare them for those scary things that they may see, to normalize them, but also prepare them for what I'll be doing. You'll be seeing me do these things. You'll be seeing me go to the pump and give this. These are what I'm looking for and why I'm giving this medication, so that they have that knowledge that can ease the anxiety of this moment. So they know that my goal is to make sure their loved one is comfortable within their goals for their loved one as well, and what their loved one has told them. So it's an honoring place to be, and a very sacred place to be in that time with family and loved ones. But with this dosing, I've definitely found that our patients are comfortable, that we can have them comfortable more quickly if they are those ones that get very symptomatic. It's a call to increase the doses, and we do get them much more comfortable in a reasonable amount of time. And then a way that we can leave them comfortable as well with adjusting our rates on our infusions. If they're ones that don't pass within that window of time, that we do say, okay, here, we're going to pass it back to the hospital, the nursing team at the bedside. We can leave them in a comfortable space on an infusion, and with further dosing that is going to be effective for them and the family. So that's that nursing role.
Am I live? Am I live? Am I real? Okay. Good morning, everybody. I want to talk to you a little bit about what the spiritual support piece can look like. I know that, as Gretchen said, we're really lucky here at Corewell Spectrum we have 3 chaplains on our team. It started out, I was the only one. I got to work with Carissa and Gretchen all the time. And now we've grown our team to 3 chaplains. I know every team doesn't have that luxury, but I hope that what I share this morning and what hopefully you've seen a little bit now and then will encourage you to reach out to the chaplains at your institution, because they really are awesome professionals that have the capacity to add another layer of comfort and kind of set the stage for the family for ongoing peace even after they leave the institution. So, I think one of the little ticks in the example we used today was that miracle talk. And that can be a big red flag, like, let's get the chaplain involved. And other families, other family units can also benefit from spiritual support, even if they don't necessarily have those kind of potentially complicating spiritual or religious language pieces playing, because we know that at the end of the day, someone that people love is probably going to be deceased, and we want to come alongside them in every way we possibly can to help them put this event into context of that individual's life and into the story of their family unit in a way that hopefully will set them up to mourn well, to grieve well, and to continue on with their own lives as well as we can when we lose someone we love. So the chaplain is going to come in. They're going to really add another kind of assessment coming from the spiritual and emotional perspective in particular, and help if there are differences of opinion or perspective or language in the family unit. If the spouse is really at peace with this and the parents maybe are hoping for a miracle, what does that miracle mean? Where is that coming from? What is that going to look like? And asking those questions, if it doesn't look like what you most hope for, how do we still live with that reality too? And that can be a delicate conversation that happens over potentially days. It might be an accelerated conversation depending on the context. I think that chaplains and everyone on this team that speaks up, I think, participates in providing education and reiterating kind of what are we doing and how did we get here and what might you see, those scary things that Carissa talked about. What are the roles? And really talking up, like, Carissa's awesome. She's done this, like, she's great. She has an eagle eye. She's going to make sure everything goes super smooth. And saying maybe in the chaplain's words what they might see too, so that there's every chance for people to grasp and comprehend what they're going through in a way that can help mitigate, not take away, but mitigate some of the natural anxiety and nerves that come along with this situation. Another key thing that the chaplain can help with is facilitating rituals. Some of those rituals are going to be explicitly religious, like they may help a family get a Catholic priest to provide the sacrament of the sick or last rites, or it might look much less religious or spiritual. It might be kind of encouraging people to take a step back from the immediate context, which can be helpful when, there's a lot going on and there's a little gap of time, and, tell me about this person and who they are and things about their life totally outside of what's happening now and about your family. And maybe getting to a place where people are invited to speak to the patient, say what they're grateful for, what they hope for, what they received from them that they will keep. It's amazing how in those conversations people will laugh, because you might expect they're going to cry, but they're going to tell stories that make them laugh and remind them of the precious, joyful things in life that are still real and true, even if this is a really, really hard, complicated day. I think another beautiful piece of that is if you have the chaplain involved early and the patient is alert prior to this transition, the patient can participate in that. I think some of the most beautiful rituals that I've ever had the privilege to observe are when the patient themselves is kind of leading that ritual and speaking to the people in their family, maybe offering them a blessing or words of wisdom or kind of teasing them affectionately. And that is a really lovely way to humanize this really tricky experience that can feel, they're in their home. It can be medicalized or learning a lot of language they maybe have never learned, and to bring it back to the human part of the experience and lift that up so that when they leave the hospital, the institution, they can keep going.
Thank you so much, Natasha. So Kira, I'm gonna move my screen around so we can see Kira. And Kira is on our team and part of the Child Life Services, and I'll have her explain more.
Okay, so like she said, I'm on the Child and Family Life team. So the purpose of my role really is to go in, meet the family, learn about the children, meet even the children, and provide them support, education, and just an independent party who they can ask questions to, who's not mom, dad, grandma, grandpa, anyone, because sometimes you don't want to ask those questions because you don't want to upset anyone. So for this case specifically, I would provide a bag that has a folder full of bereavement resources. And these resources are for the surviving parent or family member. And then they're developmentally specific to the ages of the children. And then I would also offer memory making. So I just do easy, simple ink fingerprinting on some keychains or wooden like heart ornaments or blank note cards so that the family can take that with them and have that piece and that memory of, in this case, it would be the mom. And then one other thing we also offer is a heartbeat recording for the family, and we make heartbeat bears for the children specifically so that they can have that comfort of, even though mom's no longer here, like this is her heartbeat and she's still with me in some way, shape, or form. And so that's kind of the whole resource of the Child and Family Life team. We also provide like normalization activities. So if the children were in the room during the vent removal, how to support them during that, because that can be a lot. Or maybe the children and I would step out into a separate room and we'd play some games and we'd talk through what they're thinking, what they're feeling, answer again any questions they might have. And then when the time comes for them to go back to the room after the vent removal or after the patient has passed, I would go with them then too and just continue to support them until it's known that they're kind of good, they're okay. And then I do follow-up support through the phone every so often just to check in and see how everyone's doing. And I'll send cards on the 6-month anniversary, the 1 year, the patient's birthday, and then at the holiday time, just to let these families know that they're remembered and let these children know that, like, I still remember them. They still mattered. They weren't just another patient. They weren't just another family. So yeah, the main point is really just to see the children, because so often in the adult world, children are kind of ignored or forgotten. And so that's kind of the role of the Child Life team.
Right. Thank you so much, Kira. Now I have Kayla as one of our music therapists.
Hi, everyone. Yes, as Gretchen said, I'm one of Corewell Health's music therapists, and currently I serve our oncology inpatient and outpatient populations. But for those of you that, sorry, I think my camera cut out. For those of you that maybe have less familiarity or perhaps no familiarity with music therapy, I do have a couple of slides that just give a little bit of background on music therapy as an allied health profession and some of our training and background, just utilizing music interventions to facilitate individualized goals or accomplish individualized goals. Gretchen, if you could pop to the next slide, please. A little out of order, but there we go. So just looking more widely at just music therapy and palliative care, some of the common goal areas might be physical, helping support symptom management, promoting rest and relaxation. It could be more psychological, psychosocial, emotional, patient satisfaction, offering opportunities for the patient or family members to make choices during music therapy sessions to give a little bit of autonomy and stress management, supporting some of what the chaplain is doing, offering a bit of spiritual support and connection to a preferred spirituality through music, or then closer to end of life, facilitating life review and reminiscence through music, and again, supporting relaxation and comfort care. And then can hop over to the next slide there. Just speaking a little bit more about how music therapy or music can elicit physiological responses. So music therapy can be used as a tool to help support patient vitals remaining in a desired range. Using music therapists are knowledgeable and skilled to be able to adapt different music mechanisms to help decrease heart rate or help support decreasing the heart rate to a more desired range, supporting respiratory entrainment so that respiration rates stay in a comfortable range during that end of life transition time. And then music can also elicit emotional responses and help support and facilitate family bonding during this really sensitive, sacred time. As the chaplain mentioned, just using this time is in a really intentional way for life review, whether that's recalling songs or, songs or chants or family memories surrounding music, and then facilitating some of that with the patient and family members as able. And we can to the last slide. So then during that withdrawal of advanced respiratory support, that can look like the music therapist's role can look like just procedural support at the bedside, helping keep the patient calm, helping keep family members calm so that the room stays as the feeling in the room can be as comforting and gentle as possible during this really difficult time, or what can be a really difficult time. And then also the music can serve as a stimulus that sort of diverts attention or masks some of the sounds that might be aversive or difficult for family members to hear. And then music can also be entrained to the patient's breathing to help support comfortable respiration in whatever way we can. And again, encouraging reflection, offering structured opportunities for the patient and for the family members to grieve and externally process what they're going through. And then also music therapists do a lot of work with legacy projects, whether that's, when time allows, songwriting opportunities earlier on with the patient or family members to, again, process and grieve and get some of their emotions and thoughts out into a tangible song that can be recorded. Or also building heartbeat recordings. As the child life specialist mentioned, the music therapist can use a digital stethoscope and an audio recorder to record the patient's heartbeat and set that to music that's meaningful to the patient or family members, and give that as a tangible gift to the family to remember their loved one by. So those are just a few of the ways that music therapy can be involved and support patients and families during this process.
Thank you so much. I'm just going to go back on a couple of slides to our social worker, Carrie.
Good morning. I'm glad you were on just a few minutes ago because my dog ran out the front door and got on the school bus. So that would have been an interesting situation. I'm the social worker on the hospice and patient team. I work really closely with the nurse. Typically when we come to the room, the nurse and social worker are there together. I think that's a really important thing just because we're kind of working along with each other, playing off each other, if you will. So when maybe Carissa's talking, I'm observing the room and looking at facial expressions and seeing what people are maybe thinking or feeling. So then I can, when it's my turn to address things, I can maybe address some things that I'm noticing in the room. Because when you're talking, you're not really able to observe those things. So that nonverbal observement is, I think, really important. And just to play off maybe what Carissa said, sometimes when she's explaining something, I can see like someone's maybe still confused by that or needs more explanation. So I can kind of further talk about that, but in maybe a different way that someone might understand better. So just kind of like ongoing assessment while you're in the room, reading the room, I often say is important. Educating, the nurse does a lot of this, but the social worker also does a lot of educating on, signs and symptoms of end of life and changes that are occurring. Also creating a space to reminisce. Again, a lot of these disciplines do a lot of these things too, just as Natasha mentioned. The chaplain also provides that role. As far as resources go, assessing for the needs that are outside of the emotional part. So maybe financial needs, maybe there's a medical power of attorney that needs to be done if that can still be taken place, or financial power of attorney. So assessing for some of those other non-medical needs that could be attended to that people are worried about or feel not sure if they need it or not. And sometimes that's the biggest question, is people don't even know what they need or what they even have questions about. So kind of anticipating some of that stuff too is important, especially if this is their first experience with a death. Asking questions, asking if they have worries or fears. A lot of times we don't know what we need until we address it in a different way. So identifying any worries or fears can identify additional things that they may need, resources that they need as well. Talking through funeral arrangements. Sometimes people just don't know where to start. Sometimes people have that all done and they're good with it. But just asking, like, where are you at with this? Do you need any support with it? Do you have any questions about that? That's definitely a role of the social worker to talk through those things. And one of the biggest questions people often have is like, even just the processes, like when someone dies at the hospital, what does that look like? How is the body taken away? Like, does a funeral home come right to the room? Those kinds of things are very important for families to understand and know. So much of going through these experiences is not knowing. And so normalizing the process and explaining it can take away a lot of those fears and worries, knowing what's going to happen next. And obviously, grief is a huge part of loss and death. And I think it's always important to know that there's not one way to grieve. And grief looks very different from person to person, depending on their life experiences and what they're going through in the moment, how prepared they are for the death, how sudden it is. So there's a lot of variables that impact grief, and not holding any judgment on people for how they're grieving. Sometimes people have a hard time when family members decide not to be at the bedside. And I feel like that's just awareness of knowing what you can and cannot handle. And sometimes that doesn't feel good to like providers or staff, because why wouldn't you be here? So just trying not to lay judgment on how someone might be grieving, because there are lots and lots of things from their past that we have known nothing about, and nor should we even likely get into with them. So just knowing that there's a lot more to it than just someone dying right now. So just something to always keep in mind. I think that's all for me. Thank you.
Thank you so much, Carrie. Just fast forward here through. So thank you so much for all of our interdisciplinary team members and that wisdom that you shared with us. So we're going to go back to the case, and we heard how everyone's approaching this. We have the symptom side and social, spiritual support. Children are supported. So we think if we have the luxury of time to know the day prior, we're thinking about how can we minimize chance of secretions if possible. And some of that is discontinuing any supplemental IV fluids or tube feeds if we can. This is often a just important discussion with family of why we're doing that. Sometimes if they're in the ICU already, it's like, why not start on some infusions just so we have them maybe at steady state for at least where they are before we start with just something going in the background rather than starting just from scratch at the right before. So sometimes that's helpful, and it could be low dose if they're already comfortable on the vent. It's because the main thing is you want them comfortable on the vent or whatever support they're on before we'd ever go off of it. A lot of different things listed here. Many of them we've talked about of just coordination, anticipatory guidance. So really, it's really important to talk to your bedside nurse and the team so they know what your plan is and they can give their input of like what they've known about the patient and symptom control up until this point. If they have an AICD, you can get it deactivated by the company, or use the magnet if it's more urgent. Discontinue any paralytics at least 2 hours prior. There's ways to see if it's completely worn off. And we talked about making a medication plan, some of these things we talked about. If they have restraints, we definitely want everyone out of restraints when we're coming off the event and focusing on comfort. And move on to, there's this table in that review art, in one of the review articles that talks about different things at the actual time of removing the tube. Respiratory therapists usually do a great job of getting good suctioning so that we can try to take as much of the secretions out as possible before and after that tube comes out. And we tell the family what sounds they're going to hear. Sometimes people step out for this out of the room and then come back in. It's really up to what their preference is, but preparing them for the sight, sounds, all the things is helpful. So in this patient, they had the order before comfort care of morphine every 4 milligrams every 1 hour as needed. And then, so if that was what was needed to be comfortable on the vent, what we ended up doing is just doubling that dose. So we know what's going to take more when we're off of vent support. And this situation was one of the more immediate rather than a titrated approach. So 8 milligrams of morphine was given, as well as 4 milligrams of midazolam 10 minutes prior to extubation, with link orders available for a higher dose if needed. So that power hour, this is an example of how we do the calculations, how much morphine was used, a couple of the 8s, a couple of the 12 milligrams, so 40 milligrams total. So that total amount divide by 4, and that gives you 10. So the patient had already been sort of a steady 2 milligrams an hour infusion. So we added on to that extra 10 for a total of 12 milligrams an hour. If the patient had not been on an infusion before we just started it for this process, I don't really count that infusion rate because they're not feeling that as a steady state. I just do the calculation and then that's the new rate. And then the as needed boluses, I say, what's most effective currently? Well, it was the actual 12 milligram was most effective. So that's my lower number. And then I pick something higher to go to if needed. And same with midazolam, 16 milligrams was used. Divide that by 2, and then we get 8. And then I always see, like, does this make sense? This is our estimate. So if it makes sense, then use it. If it doesn't, then do what is best based on the patient. So we added the 8 to the steady state rate of 2 milligrams an hour for a total of 10 and adjusted the boluses appropriately. So really over the next 8 hours, we're using those as needed boluses as needed. The fusion's working on reaching steady state. If we need, the providers may be contacted to adjust the boluses as needed during that time. We're not really trying to touch the basal rate because it's not steady state. So the bolus dose will increase by 25, 50, 100% based on symptom severity. And then after 8 hours, if needed, we could increase the infusion rates. We find that if the way we've calculated that basal rate, I often don't get a lot of calls during this time afterwards because that dose is very effective. And I'll just briefly share just another type of example. Instead of a vent, let's do a BiPAP removal. Jose is 75. He has heart failure, cardiorenal syndrome, low GFR. He may live some time, hours, days after this removal. We're not sure. He had morphine ordered but not used before. But we thought, if he's going to maybe live some days, let's do fentanyl. So fentanyl was used. And if this was, let's say this is on a general floor area where there's not as much nursing support patient ratio. So starting in infusion is really helpful to bolus from the pump. And so it doesn't really matter exactly what the rate is, just start low. It could be 10, 25 mics an hour with bolusing from the pump. And so another example of calculations, if 175 was used, we divide that by 4, got 43. So I estimate, and these are true numbers for my case, we started at 50 mics an hour and then adjusted our PRN boluses and did the same type of calculations that we do for the midazolam. And so here I just used that rate we calculated because we had just started that infusion. I didn't add that an additional 10 micrograms. So those are examples of how that can be used. And the main points of communication between the providers and the nurses are planning and what those initial orders are, then that 1 hour after that power hour is what we call it whatever you'd like. And then to calculate where that infusion's going to stay if they're on an infusion. And then 8 hours after, there may be communication if that infusion needs to be adjusted. So some takeaway points is think of opioid infusions like long-acting medications and wait until steady state is reached before titration. Have a linked order for your opioid and benzodiazepine with a lower and higher dose option and titrate as needed. This is for that acute symptom management. And then just the importance of that interdisciplinary team support is just essential to the exceptional experience for patients and their families. And I also highly encourage people to look into and incorporate the RDOS score into your practice, as it is a validated tool that's really in all the recent review articles as something that's highly recommended. And just contact information for everybody who was talking here with us today.
Thank you so much, Gretchen. This is great. Couple of points. First of all, if you've not yet written this up, you need to kind of formalize this. It's probably long for a standard article, but at least a monograph, because how you've integrated the team into this, and I love your math. It just takes me back to the time when we did about by guess and by golly, you know, and how it doesn't frighten me to think of the things that we did in previous decades, but this is just so rational and it works so well, and I appreciate you doing this. And again, integrating the team into this, I think was wonderful. I also want to encourage others, because you had mentioned a couple of times, you know, that you're blessed and fortunate to have so many of these different team members available. And I would just, however, submit that in most hospital systems, we have a bank of talent. It may not be that they are necessarily dedicated to a palliative team, but my suspicion is that they're there. And so seek them out and use them as you can, because it makes such a difference in the life of the patient and the family. So anyway, and just this is a really minor aside, but just it touched me for a moment. Your first article with Randy Curtis out of University of Washington there. Randy was one of the seminal pioneers in ICU palliative medicine. Died 2 years ago from ALS. And every time I see one of Randy's articles, I knew Randy well. Got a little choked up, but so thanks for reminding us of the work that you did. Questions, comments for Gretchen today?
Yeah, for me or anyone who spoke.
Like there's a comment in the chat.
All right, so that's a comment I got. For crisis management of excessive secretions, gurgling, flash pulmonary edema following extubation, consider IV atropine. Those with high pressure PEEP settings are vulnerable. Comment from Fred. Thanks for that,
Yeah,
Fred.
thank you. Yeah, and I think people can share too their best practices if there's things that you find effective that haven't been working here. There's not always literature to support things that can work, and so I think we just end up just trying anything we can, and a lot of it's too trying to talk the patient family through. They're sedated. They should not be feeling pain, but it's very uncomfortable for family to watch and hear those sounds and noises too.
I have a quick question for Kayla. You had mentioned some of the legacy, mixtapes that you make, and how you touch upon the musical genres. You also mentioned songwriting. Is that something you personally do, or do you have a team, or how do you convert someone's story into song?
Yeah, that's a really great question. Thank you. So that's something that is usually done at the bedside, especially when we have a little bit more time and I'm able to build rapport with the patient beforehand or with family. But to be able to sit down and just let some of those stories flow, let some of that life review happen, and have some prompts to help facilitate that and support it. And then really kind of best practice for music therapists is to present a few different maybe musical ideas or melodies, but really provide as much autonomy for the family as possible so that they feel empowered to make choices about how that song comes together. And so they really feel, they have this sense of pride and involvement in the final project that gets recorded. So that's something that can happen over the course of, a 30-minute music therapy session, or with the luxury of time, if I'm able to have a few music therapy sessions, it's something that can be done over the course of a few days or something like that. But something that can be quite simple and come together. And that's kind of the nice thing about a music therapist having the musical training and background and specialization in that to help support the family, so it's not too cumbersome of a process.
Yeah, thank you for that. I think it's such a wonderful gift to be able to leave with people. A couple other quick questions here. Gretchen, Ryan has a question about Precedex and semi-awake. Do you discontinue this along with starting a usual meds?
Yeah, great question. Precedex is one that I find it can continue. I mean, sometimes they don't need it, but if it's been very helpful, sometimes it just works differently. I just keep it on and then add them on midazolam on top of that.
Different mechanism, so it's complementary. I get
it's complementary. And Linda's question process, educating nurses, this was way harder than I thought. And so it was a lot of teaching. I made recording and videos of the why. I get in-person sessions. We'd go to rounds and explain as with the charge nurses. So trying to go to nursing council meetings. So it took a lot of just time and showing up and explaining. And then every case by case, our nurses explaining what we're doing, why. And now that they see how effective it is, it's what we do and how we do it. But it was hard. And so I'm happy to talk to anyone who's working on culture change at their hospitals, but you can't just change practice and hope that everyone else comes along. We have to provide that why and the research and the education.
So I'd encourage people, this lecture and the PowerPoint will be uploaded to the YouTube channel, and I would encourage you to download that. It's got as Gretchen pointed out, it's got the contact information for the various disciplines there, and it's just good reference material, especially with some of the calculations and formulas there. So thanks again, Gretchen. Thanks again for the team bringing this together. It's been wonderful.